All right, today we're doing something a little different. We are putting you right in the hot seat for one of the toughest tests a surgeon will ever face, a consultant-level oral exam. The case we're looking at? A terrifying, fast-moving infection called necrotizing fasciitis. The patient's life? Well, it's hanging on every single decision. Let's get started. So, what you're about to see is based on a real oral exam scenario from the Saudi Commission for Health Specialties. This isn't just about textbook knowledge. Oh no, it's a real test of how you think and act under some serious pressure. You're going to hear two voices, the examiner who's running the show, and the candidate who's trying to save a patient's life one right answer at a time. We're going to walk through this case just like it would unfold in a real exam room. We'll start with the patient showing up at the door, move through the initial life-saving steps, figure out the diagnosis, manage the emergency, deal with the crisis after surgery, and finally, plan for the long road to recovery. Okay, the scene is set. The exam has officially begun, the examiner is staring down the candidate, the clock is ticking, and the pressure is on from the very first word. You are the surgeon on call. A 45-year-old man is in the ER critically ill. He is 2 days post-hemorrhoid banding. Okay, so my initial thoughts are swirling. We've got a 45-year-old man, and right off the bat, he's got major risk factors, diabetes and morbid obesity. And he is presenting in what looks like profound shock. I'm seeing cyanosis, he's breathing way too fast, his skin is cool, and he's not all there mentally. This guy is circling the drain. You know, when a patient is this unstable, those first few minutes are absolutely everything. The examiner's next question is designed to test the most basic, most important skill in a crisis. Can you prioritize? It all comes down to the ABCs: airway, breathing, circulation. A systematic approach here isn't just good practice, it's what they're looking for.
How would you approach him on arrival?
Right. First things first, I'm sticking to the ABCDE approach. A for airway. I'm going to make sure it's clear and get him on supplemental oxygen immediately. B for breathing. I'll be watching his O2 sats like a hawk. C for circulation. I need 2 large-bore IVs, now. While we're getting those in, we'll draw blood for all the baseline labs and start hammering him with IV fluids, Ringer's lactate. All the while, I'm constantly reevaluating his vitals.
After starting oxygen and pushing 2 liters of Ringer's lactate, his oxygen saturation is only at 92%. He's still hypotensive, his heart is racing, his temperature is 39 degrees Celsius, and his labs are back, showing a severe metabolic acidosis. He is not responding.
And here's the twist. The initial resuscitation isn't working. That's a huge red flag. It tells you the problem underneath is massive and isn't stopping. So now, the candidate has to pivot. They have to shift from just stabilizing the patient to finding the source of this septic shock. And they have to do it fast.
What will you do next? Okay, the resuscitation continues, but at the same time, I need more info. I'm going to get a detailed history. I want to know everything about his perineal pain, any trouble with urination. I'll confirm his past medical history, what meds he's on, and any allergies. And then I need to put my hands on him for a focused physical examination.
Your examination confirms the patient is critically ill and in shock. You find significant tenderness, redness, and heat spreading from the perianal area up to the scrotum and across his gluteal region. What is your provisional diagnosis?
This is a life-threatening perineal sepsis. My provisional diagnosis is necrotizing fasciitis, what's also known as Fournier's gangrene. This is a flesh-eating bacteria, essentially. It's a runaway infection that's just destroying his soft tissue, the skin, the fat, the muscle coverings. This is a surgical emergency of the highest possible order.
And there it is, the diagnosis. You know, naming the beast is half the battle. But now comes the fight. The candidate has to lay out an immediate, aggressive, no-holds-barred plan to get this raging fire under control before it consumes the patient.
My management plan is immediate and has multiple parts. 1. Get him to the ICU for close monitoring. 2. He's NPO, nothing by mouth. 3. Continue to pour in IV fluids and start broad-spectrum IV antibiotics right now. 4. We manage his pain and get his blood sugar under control. But the most important thing, the absolute #1 priority, is getting him to the operating room for urgent radical surgical debridement. And I mean now.
So the patient has had this surgery. But in a case like this, you have to understand the battle is far from over. That infection has already unleashed a storm of toxins throughout his body, and now the candidate is facing a brand new crisis up in the ICU.
The patient was taken to surgery for a wide excision and debridement. He's now in the ICU. Despite aggressive fluids and starting norepinephrine to support his blood pressure, he remains profoundly hypotensive. By postoperative day 2, he is still deep in septic shock, with his organs starting to fail.
The patient remains hypertensive on norepinephrine. Which is the next appropriate medication to add?
Okay, since he's in refractory septic shock, meaning the first-line treatment isn't working, the next drug to add is vasopressin. See, norepinephrine is a vasopressor. It squeezes the blood vessels to raise blood pressure. When that's not cutting it, vasopressin is the standard second-line agent. It just works through a different mechanism to do the same job.
On postoperative day 2, despite maximum medical therapy with 2 powerful vasopressors, the patient is still in septic shock. What is the most beneficial course of action now?
The most beneficial action is to take him back to the operating room for a second look debridement. The fact that he's still in shock tells me there's still a source of infection we haven't gotten out. We have to be relentless. We have to go back in and re-excise all of the dead, non-viable tissue until we see nothing but healthy, bleeding tissue.
And that answer right there illustrates a core principle that every single examiner wants to see. With necrotizing fasciitis, if the patient is not getting better, the answer is almost always more surgery. You simply cannot save them until you have completely removed the source. So now, with the infection hopefully under control, the examiner shifts to dealing with the aftermath.
After this second debridement, the perianal wound is going to be massive. The plan now involves meticulous, regular dressing changes, and we have to maintain a really low threshold to go back for more debridements if we need to. And crucially, to protect this huge open wound from feces, I will perform a colostomy to divert the stool stream.
Which colostomy would you choose? I would perform a sigmoid loop colostomy. It's a relatively quick and effective procedure that completely diverts the fecal stream away from that perineal wound. This is what's going to give him the absolute best chance to heal. It's about definitive source control.
You know, this case is a pretty brutal reminder that in a true surgical crisis, getting the diagnosis right is just the starting gun. The real test is managing the chaos that comes after. It's the relentless fight against shock, the repeated trips back to the OR, and having the courage to act aggressively when your initial plan just isn't working. So it really leaves us with one critical question. When you're faced with that kind of chaos, are you prepared to act and then act again?